Welcome everyone. This is your moderator and we will be starting our webinar promptly at 11:30 right now. Today's webinar is sponsored by the Pennsylvania Department of Health and the Pennsylvania Breast Cancer Coalition. Big thanks to the Data Advisory Group of our Pennsylvania Cancer Plan for putting all these slides together for us. I am Julia Bucher. I am your moderator. I have a very few housekeeping points and then I'll introduce our panel. Each panelist will be speaking for 10 minutes and then by 12:15 we'll open up for question and answer. We've received some questions already, but if you have a question, please write it in the lower right-hand corner. There's a chat box. Please limit your question to just the 4 cancers that we're covering today. And if we don't get to your question, all attendees today will be receiving the entire list of questions and answers that we have, whether we discuss them on the webinar or not. So please limit your questions to the 4 cancers today. And I get to tell you that there'll be a second webinar this fall that will be addressing the burden of other cancers. Also, all of you are going to receive an alert on email when this webinar is posted as a link on a website called Live Healthy PA, where many materials will be housed. So with that, I want to introduce all 4 of our panelists before I turn it over to the first presentation. Today, we have Dr. Mary Simmons with us speaking on breast cancer. She's in Harrisburg as a medical oncologist with Andrews and Patel Associates. Speaking on cervical cancer will be Robert Edwards. Dr. Edwards is a member of our Pennsylvania Cancer Control, Prevention, and Research Advisory Board. He's speaking with us from Pittsburgh, where he's the director of the University of Pittsburgh Medical Center Health Services, Transformational Medicine, and he also is a professor and chair of one of the departments at the University of Pittsburgh School of Medicine. On colorectal cancer, we have Carmen Guerra. Dr. Guerra is the Associate Director of Diversity and Outreach and an Associate Chief of Staff at the Abramson Cancer Center in Philadelphia. She's also an Associate Professor and in the Division of Internal Medicine with the Department of Medicine at the University of Pennsylvania. And finally, speaking on lung cancer is Dr. Troy Moritz, who's here in Harrisburg in the Central Region with Pinnacle Health Cardiovascular and Thoracic Surgery Associates. And with that, I'm going to turn the first set of slides over to Mary Simmons, reminding the audience that you cannot ask a question directly. You are on mute, but you can send a question in through your chat function. Our data sources today come through many different places, and the Data Advisory Group has used data from this list that's on your screen right now. And with that, I'll turn it over to Dr. Simmons.
Thank you. So it's a pleasure for me to be here today, and I thank the Department of Health and the Pennsylvania Breast Cancer Coalition. My understanding is that of a growing number of attendees I see on my screen, we're now 110, it is somewhat of a mixed group. So in breast cancer, the first remarks I have to do with screening, and I want to say just a quick word before I address the slides, and that is that breast cancer is in fact one of the cancers, because not all cancers are amenable to screening, but it is in fact very well proven that with screening in breast cancer, it makes a difference in the ultimate aim, which is survival. Because first of all, breast cancer is common in the population, and also the screening tools are in fact sensitive enough to find a breast cancer, a primary cancer, when it is too small to feel, and the smaller the breast cancer directly correlates with the better chance of survival. The tool I'm talking about, of course, is mammography. It is not a perfect tool, although there certainly have been advances in imaging over the past 10 years. To discuss the technology today is beyond the scope of this report. But I did want to point out that there have been regulations in place in the state of Pennsylvania, in fact, for decades, assuring women that when they go for their mammogram, the equipment, the machinery, meets standards to, in fact, accomplish finding an early cancer, and also the interpretation, that is, the radiologists do have the needed competency to interpret the mammogram appropriately. The other last point about an introduction is that the screening guidelines, a number of national organizations have guidelines. They get talked about from time to time. Sometimes there's actually a reason they might be slightly revised, but in the last number of years, I would say that all national groups pretty well agree, and basically it would be to have a mammogram in every woman over the age of 40 every year, especially if they're generally in good health. All right, with that said, my first slide has to do with women, females 40 and above who have had a mammogram in the past 2 years. And these are data, as I think everyone can see on the screen, 1995 to 2010. And the rate of mammography is then close to 74% in Pennsylvania, and there are actually national statistics to say that that rate is 75%. So that Pennsylvania, we're very close to that national number. Obviously, ideally, it should be 100%, and in fact, as I alluded, the mammogram should be given every year, and that may be where people in the audience are in a position to improve those numbers. On my second slide that I chose from this report, we drill down a little bit into the data, and this breaks out the data by race and ethnicity. And black women, interestingly enough, according to these statistics, have the highest rate of having a mammogram, and you can see it's 80%. Across the United States, that number is 78%. The multiracial, as this data presents, is actually the lowest at 49%, and there is U.S. data for that as well, and that's 60%, so it's also lower across the United States. And then on my next slide, we break the data down by age group. So the highest compliance with having a mammogram would be ages 50 to 59 at 78%, and it's pretty close for the next quartile as well, which is ages 60 to 64 at 78%, and across the United States it's 79%. On my next slide, Pennsylvania has data to break this down by income and education, and this is probably not much of a surprise, but women with the lowest income have the lowest compliance, and also the women with the least education. Often those two actually go together. Okay, and my next slide breaks it down by region of the state. This is data in 2012, a mammogram in the past year. So the highest compliance is actually the city of Philadelphia at 64%, and the lowest is actually in the Northeast, the Southwest, and Allegheny County, ranging from 56 to 60%. So that tells us something about screening. And then we have data to discuss on incidence and mortality. So breast cancer is common in the population, as I already said. It's one of the top 3 cancers all across our country and as well in Pennsylvania. It's roughly 1 out of 8 women. So the first slide that I chose from the report has to do with incidence. And also, this slide also breaks it down by race and ethnicity. The first point, though, is for all races and ethnic groups, the incidence is basically stable in the past decade. The Asian PI has an upward blip there in the middle, but it basically averages out. And it's stable in Black, the Black population as well, I might point out. And even though there's that blip in the Asian population, there is less incidence in the Asians and the Hispanic population. And we might speculate about that in the questions. But I'd like to move on then to the next slide. And this shows the data for mortality. And notice that the Black women do have the highest mortality. And we'll be talking a little bit more about that. So on the next slide, we can start to drill down. I think everyone knows that any pathologist that makes a diagnosis of breast cancer in the state of Pennsylvania now for a number of decades, it is by law reported to the Department of Health. So that's where some of this data comes from in the tumor registry, and they have enough data to break it down by stage. And this would be the TNM stages, tumor node and metastasis is what that stands for, and these are standard definitions. So the pattern is pretty similar across all races, I would say. But I'd like to point out in the Black females, there is at least a slight increase in what's called regional, which would certainly be nodal, and distant disease, which would be metastatic. And then two more slides to discuss would be the data in this report about hospitalization. So this data can be captured by discharge diagnoses, and notice that the rates are going down. So that's a good thing. As a medical oncologist, certainly we give the treatments, specifically chemotherapy, more and more and more in our offices as an outpatient. And medical science has developed growth, we call growth factors, specifically Neupogen and Neulasta, which brings the white count back up much quicker. So there's less risk of neutropenic fever, which would be one common reason for a hospitalization associated with breast cancer. And secondly, pharmaceutical industry has developed now a number of antiemetics that are much more effective, especially considering when I started practice. So we have less dehydration, less complications of that, and that would be another reason for less hospitalization. And lastly, we have hospitalization rates broken down by race and ethnicity, and they're all tending to drop as well. So that would conclude my remarks for the morning.
Thank you very much, Mary. And we're going to move on to our second presenter on cervical cancer, Dr. Edwards.
Good morning. I appreciate the opportunity to present this data to the webinar audience, and want to give my thanks to the Department of Health for allowing me to be involved. Cervix cancer, like breast cancer, keeping on our theme of women's health screening, is among the four cancers we're discussing, the cancer that has the screening test with the most history and track record. It's been used broadly in the population since the late 60s, early 70s, and the screening test as a modality has been consistently adjusted, and the rate of screening decreased as we become more comfortable with the technology. The goals of what we're going to present today are to try to identify for the state of Pennsylvania the highest burden populations, the geographic areas with the highest burden, the lowest screening rates, and see if we can correlate that to identify communities that might need targeted interventions. We're also going to look at hospitalization data, and there are some themes among these cancers with regard to hospitalization data among the 4 cancers. Next slide. The highest burden incidence for cervix cancer is significantly borne by Black women, and in some years, and there's a fair amount of variation in these statistics, it's actually almost twice as high for Black women as compared to white women, and that is a consistent finding that does not appear to be improving with time. I'm sorry, could I have my next slide, please? Next slide. Hello?
There you go.
Okay. The highest burden population for mortality is African American women, and the death rate consequentially is in fact twice as high for Black women as compared to white women across the state. So these are concerning data. The variation of data relates to the small numbers in each category as compared to some of the other cancers that are evaluated. The incidence of cervix cancer, I should point out, was much, much higher before the advent of the Pap smear, and worldwide, where Pap smear screening has not been instituted, is the second highest cause of death in women in the world from cancer. Next slide, please. The next slide shows the highest burden by age and by race, and you can see, as I pointed out in the previous slides, that African American Black women have not only a higher incidence but a higher death rate, and this is consistent in all the data throughout this presentation. And to be honest, I'm a little bit at a loss to explain all these effects. As you're going to see in a minute, the screening rates do not account for this. The next slide presents the burden across the population by age, and you can see, as it's been known for years, that the incidence of cancer increases as women age into their 30s and peaks in the mid to late 30s and early 40s, and then begins to decrease. And this says something about the biology of the human papillomavirus and colonization and the long prodromal period until the cancer actually develops. This prodromal period provides the opportunity for the Pap smear screening to intervene. But in women who are not detected by Pap smear screening, the death rate rises substantially, particularly as women approach the 50s and 60s, and this is likely related to late detection. By late, I mean advanced stage, not advanced age. And so many of these cancers can be controlled local regionally for a while, but women eventually die of distant disease. The vast majority of early stage cancers are, in fact, cured by a combination of either surgery or chemoradiation. The next slide reveals the geographic distribution. As you can see, the U.S. rate is 6.8. Pennsylvania rate is higher. But if you drill down to individual counties, you see the areas with low populations have highly variable rates. And I think the phenomenon we're seeing here is the small numbers in each individual county. But as you'll see in a few minutes, the screening rates vary widely across the state in many of these rural areas, and that is likely due to access issues and education issues as well as compliance. Within the urban areas, we see that the actual rates in Allegheny County are below the U.S. rates. In Philadelphia, however, the rates are particularly high in terms of cancer incidence. And as you can see, as I mentioned previously, there's a high degree of variability from state to state, and that has to do with the small number of incident cases in each county within the state. Next slide, please. So this is where we really have a moment to pause and look at the impact of what we're doing. We do appear to have high degrees, very similar to mammography, of compliance with screening. It's in the 70% range throughout the region in all 6 quadrants of the state. Allegheny County, the Philadelphia area, it's exceedingly high, and yet we continue to have this disparity in African American women. And to be honest, I don't have a good explanation for this. Presumably, participation in screening in the last 3 years is sufficient, and by the existing data should produce reductions. 2 possibilities would be that the screening rates have increased recently, in which you wouldn't see a consequential decrease in cancer incidence for several years after that due to the prodromal nature of the disease, or there's inherently a different biology in black women as compared to white women. Possibilities that have been written about nationally about this might include earlier age of first intercourse, which may produce increased risk for African American women, or potentially other cofactors. But it's not unique to Pennsylvania, and the current screening approach, at least to this point, has not brought the black cervical cancer rates down to a comparable level as they are with white women. Next slide, please. Contrary to popular perceptions, a surprisingly high number of these individuals have commercial insurance and or Medicaid, and so resources are there to participate in the screening, and the hospitalization charges are covered. The perception, I think, for cervix cancer, which goes back to the early 1900s, is that this is a disease of the poor and underserved, and therefore many of these women are not covered by insurance. But in fact, the lion's share are in fact covered in the state of Pennsylvania, and most states have some active program to make insurance available to women for both screening, or make coverage available to women for both screening activities as well as for treatment of incident cancers. Next slide, please. The next slide describes the hospitalization data and cost, and much like in breast cancer, we're seeing reductions in the cost of cervix cancer treatment. This is likely attributable to the reduction in the number of admissions for active treatment. We have shorter length of stay for inpatient therapies, including radical hysterectomy and radiation. Many of these therapies are given with overnight stays or even outpatient approaches, depending on sophistication of the treating center's radiation equipment. And many of the early stage cancers are being managed with more conservative surgery, which also reduces your cost as well. So there are success stories to be had with regards to the hospitalization rates. We just would like to see a better trend in terms of the overall incidence. So we reviewed very briefly the highest burden populations, the geographic areas that appear to be at risk. We've identified the screening rates and where there may or may not be issues relating to screening participation, hospital and cost, and communities that might need targeting, and this would include urban areas and possibly rural communities where they have very small individual numbers of cases in each county, but if you add the cumulative incidence, it appears to be contributing significantly to the overall cancer rate for the state. Next slide. My final slide is this is cervix cancer screening is a mature, accepted modality. It has already had a maximal impact on cervix cancer incidence, and the low incidence relative to screening would suggest that, except with very high-risk populations, which go beyond the scope of this data, there's not much to be added by additional scrutiny of screening, except to make it available in areas where access is limited and or where patient education and compliance is not available. Next slide, please. The good news is the problem with cervix cancer screening and pap smear testing is it requires compliance and it requires completing or doing recurrently or repetitively, and that is a significant healthcare cost. There's a welcome new modality, HPV vaccination, and I believe much of the CDC's as well as the state of Pennsylvania's attention to this disease is going to focus on vaccination strategies that may reduce in the future the need for such a widespread screening program. Currently, we need to continue the screening until the percentage of the population that's been HPV vaccinated reaches a critical area. So that's my last slide for my presentation, and I appreciate the opportunity to speak to you today.
Thank you so much, Dr. Edwards. Now we'll move on for facts about colorectal cancer with Dr. Carmen Guerra.
Thank you very much for the pleasure to speak with you today, and I want to specifically thank the Department of Health and also thank the audience for sharing their valuable time with us today to better understand the burden of cancer in Pennsylvania. I have 12 slides, and the outline of the slides will be that we'll first discuss the trends in colorectal cancer, and then the burden of colorectal cancer across race and ethnicity, and then geography. And then we'll look at screening rates in the state, and we'll end with some conclusions and a call to action. So I'd like to begin with this slide that shows the trends in incidence by race and ethnicity in Pennsylvania from the years 2000 to 2011. And I feel like the bearer of good news, because what you can discern is that the actual incidence rates in Pennsylvania have actually been decreasing. These curves show that Black men still have a higher rate of incidence of colorectal cancer, followed by white men, and then Black female, and then white female. So that is the trends in incidence, and if we go to the next slide, we'll see the trends in mortality, and they're quite similar. There's a decreasing trend in the death rates, and the highest rates occur in Black male, followed by white males, and then followed by Black females, and then the lowest are in white females. So if we go to the next slide, what we can discern from here is that there are some racial ethnic disparities, and this slide includes more race and ethnicity populations other than Black and white. As you can see from the bottom, this slide also includes Hispanic males and females, and it also includes Asian males and females. And again, we've already discussed how Black males have a higher incidence and death rate of colorectal cancer, and that's shown here in a different format. But I included this slide because Pennsylvania is a very diverse state. And you can see here that the Hispanic males and females rates of incidence and mortality are actually lower than white male and female rates. And Asians have the lowest mortality rates of colorectal cancer, as you can see here as well. So if we go to the next slide, we'll switch over to the burden of cancer across geography. And there are 4 slides here. And the first will begin with incidence, and we'll look at male and female. And then the second 2 slides are mortality, and we'll look at male and female again. And you can see the U.S. rates of male incidence of colorectal cancer, as well as the Pennsylvania rates. And what we see here in orange is the counties that have the significantly highest rates of incidence of colorectal cancer. And Cambria County actually has the highest at 70.7. Fayette County, Luzerne County, Schuylkill County, Philadelphia, and Delaware stand out as the counties with the highest incidence. If we go to the next slide, we'll jump to females, and you can see the counties here that have the highest incidence of colorectal cancer. Here, the highest would be Clarion County, followed by, as you can see, Schuylkill, Lycoming, Mercer, Philadelphia, and Delaware counties. So that was incidence. If we jump to the next slide, we'll look at colorectal cancer mortality. Again, we'll start with males. And as far as mortality is concerned, you can see the U.S. death rate as 19.6. The Pennsylvania death rate is 21. And here, Philadelphia stands out with the highest death rate in male colorectal cancer mortality at 26.8, followed by Luzerne and Delaware County. And if we go to the next slide, the final slide is the females. And here, the Pennsylvania death rate is 14.6, and you can see again Philadelphia is the highest rate at 16.2, followed by Delaware at 16.5. So that was the burden of cancer across geography. Because screening has been shown to be extremely effective at reducing colorectal cancer incidence and mortality, the next slide will show what the screening rates across Pennsylvania are. And here we'll have two slides. The first will talk about colonoscopy and sigmoidoscopy, and the second slide will look at fecal occult blood testing. So on this slide, what you can appreciate is the number of Pennsylvanians who are over 50 in 2012 who had colonoscopy or sigmoidoscopy in the last 10 years. And green is good, so the green portions of the state have the higher rates of screening, whereas blue is the lower rates of screening in the state. And what you can see is that the southwest corner of the state has the lowest screening rates at about 60. If we go to the next slide, this one shows the rates of blood stool testing using home kits in the past year. And you can see that the Allegheny County as well as Philadelphia have rates of 8%, the lowest among the state. So a few conclusions if we go to the next slide are that the highest burden populations of colorectal cancer in the state of Pennsylvania are among populations that are Black, particularly Black males, followed by white males, then followed by Black females. Next slide. And geographically, the burden of the highest male mortality for colorectal cancer is in Luzerne and in Philadelphia and Delaware counties. And for female mortality, it's in Philadelphia and Delaware. Next slide. As for screening rates by region, the lowest colonoscopy and sigmoidoscopy rates, as we saw, are in the southwest corner of the state, and the lowest FOBT rates are in Allegheny, Philadelphia, and the northeast part of the state. And the final slide I have is a call to action. Because we know that colorectal cancer screening is highly effective at reducing this burden, and because all the guidelines recommend colorectal cancer screening in our patients over 50, we can do better. And so the call to action is for the leadership of the state, the Department of Health, the health systems, the payers to come together and move the needle on colorectal cancer screening rates. And ways that we can do this include by working with providers and health systems to offer all the recommended test options and match the patients with the test that they're most likely to complete. Patient navigation is increasingly cited as evidence-based intervention to increase colorectal cancer screening rates, so expanding patient navigation programs, developing business models to implement successful programs. This is what we need to move the needle on colorectal cancer screening in the state and in the nation. And finally, making the accessibility of FOBT and FIT kits in places other than the doctor's office is also an evidence-based technique that has been shown to increase uptake of FOBT and FIT by various populations. A researcher by the name of Michael Potter at UCSF introduced the concept, which has come to be known as flu-fit, or flu FOBT programs, where in flu clinics, physicians and providers are able to hand patients a home fecal occult blood testing kit or fecal immunochemical testing kit, and this has been shown to increase rates to up to 90%. So these are some of the ways that we can think about going forward, and I appreciate the opportunity to bring you this information, and we look forward to working together, all of us here in Pennsylvania, to moving the needle on colorectal cancer. Thank you.
Thank you very much, Dr. Guerra. And now, covering lung cancer will be Dr. Troy Moritz. Troy?
Unmuted. Hi there. I just wanted to first off say thanks for the opportunity to be involved in this presentation on trends and insights of cancers in Pennsylvania, brought to us by the Pennsylvania Department of Health. I think this is a great opportunity. And I also want to thank the other presenters. I did learn a lot about your particular areas of expertise, and I hope all the attendees have learned something as well. My first slide is lung cancer incidence, a similar slide that we've seen for the other three types of cancer. The incidence of lung cancer is climbed as far as its position. It's, as of 2011, the most common cancer in Pennsylvania, but its rate is down. In particular, you'll see that in the black male population, there's a decrease in the incidence, and in the white male population. This same decrease isn't shared equally by the female population. Both the white female and the black female population are a little more flat or static in their trend, and this does correlate a little bit with quitting smoking rates. Female population did seem to decrease their smoking consumption several years behind the male population, and when you look at national data. And I don't know if you see that on 2007 is when the incidence of female lung cancer peaked. Next slide. If we want to look at cancer death rates, the interesting thing I found on this slide was that the black male mortality rates are actually down significantly compared to the white male rate, even though the incidence of decrease in smoking is similar. But once again, we see sort of a static or a flat curve here for both the black female and the white female population. And interestingly, we're not seeing the same kind of drop-off as we would expect in that's come after the drop-off in smoking rates. Next. So overall, one of the burdens or challenges that we have with lung cancer is that about 75% of lung cancers are diagnosed at later stages. And we need to do something to improve earlier diagnosis, and especially being that lung cancer accounts for 26% of all cancer deaths. That's about 7,600 cancer deaths. It's a big burden in the state of Pennsylvania. It's over the amount of colorectal and breast combined. The next slide on lung cancer staging data. We don't do a good job, as the previous slide pointed out, finding cancer at its earlier stages. The thing that does not correlate on this slide with the previous slide is that even though there's a significant decrease in the black male population as far as their death rate goes, we don't seem to be finding it at an earlier stage as you would expect, because that's where we can actually impact cure and treatment and survival. So I'm not sure why those two don't correlate, but it is just an interesting side note. The lung cancer screening is relatively new, and so it's something that's only been around for the last couple of years, and was only approved by Medicare in February. So I don't have data and slides on how effective we are at screening yet. We look forward to seeing some of that data in the future years when the cancer statistics in Pennsylvania are analyzed, and I'm sure that all the rest of us that are involved in lung cancer care will be very interested to see how this staging at diagnosis graphs here are impacted by lung cancer screening. Move on to preventing lung cancer. The biggest thing we can do is don't smoke. Reports are anywhere from 85 to 90% of lung cancer is caused by smoking, and that's a very well-known fact. The other piece of information here that most people don't know that I find to be sort of new on the radar for everybody is that radon is a big issue. It's the second leading cause of lung cancer, and so it's an issue that I'm happy to talk about whenever I get a chance, just because I'd like to raise awareness on radon in both the home and the workplace, as well as schools. So what you can do in your workplace is you can prevent asbestos, radioactive ores such as radon, inhaled chemicals, minerals, diesel. Exhaust is another kind of common cause of the lesser-known lung cancer causes. If we move on to the next slide, I put this in here about the smoking rates because I think Pennsylvania's done a fairly good job in decreasing smoking rates, and I think that's why our lung cancer rates are coming down, and the Department of Health has done quite a few wonderful things over the last decade to do that. The smoking rate in Pennsylvania, as you see in the middle of the graph there, did peak. It was about 25.4% in 2003. Unfortunately, we're down to about 18% currently. Now, the national average is 17.3%, so we're not that far off the mark there. The next slide, if you look at who's currently smoking in the state of Pennsylvania, this correlates with some of the other information that, like Dr. Simmons presented on breast cancer, is we see a higher incidence of smoking, therefore we see a higher incidence of lung cancer in the lower income households, as well as those households that have less than a high school education. The next slide is another touch on radon. According to the PA Department of Environmental Protection, PA has one of the most serious radon problems in the nation. Estimated that over 40% of homes in Pennsylvania have a elevated radon level above the 4 picocuries per liter that's recommended. There's a link here that you can go to learn a little bit more about radon, and I think there's also information on there on how you can obtain radon test kits for your home. The next map shows us where radon levels are significantly higher than the 4 picocuries per liter that's recommended. So you can see a good bit of the state falls into that. Now, I just want to point out that you can have high radon levels even in the lower or significantly lower areas. So it is recommended that you probably should have your home checked, and all types of homes can have high radon levels. So if we move on to sort of general observations, this is very similar to the colorectal data that Dr. Guerra just pointed out a few moments ago. We see our highest burden of lung cancer in the black male, the white male, and the black female population, as well as those with the lowest education and the lowest income in the state of Pennsylvania. So those are the populations that we need to reach when it comes to improving statistics on lung cancer. The next slide goes over that. Pennsylvania does have quite a few resources available to quit smoking. The second thing you can do is ask your physician if you qualify for lung cancer screening. Like I said before, this is relatively new as far as lung cancer goes, and it's also now approved by Medicare and some other insurers, so it is something that can be done, and we hope to see the significant improvements in survival that other cancers that have national screening guidelines and recommendations have seen in their cancer statistics. The improvement in survival has been pretty impressive, so we're hoping to get the same thing for lung cancer. And if you haven't ever had your home tested for radon, that's another good way to prevent lung cancer, is to go out and do that as well. That's basically my wrap-up on lung cancer.
Well, thank you, Dr. Moritz, and thank you to all of our presenters for staying on time. That opens up our question and answer period now. And looking over the questions, the first one is for the Pennsylvania Department of Health. One of their staff members, Sharon Sowers. Will any funding follow this cancer burden discussion? Sharon?
The purpose of our webinar today was to increase awareness about incidence of these 4 cancers. give everybody on the line today information about incidence and mortality in Pennsylvania so that our communities, if you're representative of an organization or business, so we can all work together to try to find collaborative approaches for increasing cancer screening and prevention opportunities. We also, secondarily, the reason we had the webinar today was so that we would give you information of how you can access data and research for decision-making purposes, grant writing, etc. We do not have any additional funding opportunities planned as a result of this webinar. Our Cancer Advisory Board and our stakeholder leadership team, Statewide Cancer Coalition, are already engaged in a number of preventative screening and educational opportunities. Anybody who is on our call today who would like to get engaged in one of these opportunities, please let us know. Thanks, Julia.
And they can do that with just an email, Sharon?
Absolutely.
All right, thank you. And I'm reminding everyone that there will be a link sent to you for today's webinar that has been recorded. Don't expect that immediately, but when it's available, we will send it to you. I'll take the next two. They're more on epidemiology data. How is the hospitalization rate defined that was used in the slides? This rate was based on primary discharge diagnosis of the disease, but per the general population, not for the population with the disease in the geographic area. So its primary discharge diagnosis creates the hospitalization rate, and it is age adjusted to the 2000 standard population. And what are age adjusted rates? Well, they are sort of the gold standard in epidemiology and in interpreting data. Age adjusting is used so that age groups with different age distributions, like more or less people in that age group, so that we can compare them across different age groups. So a formula is applied to the numbers for incidence or mortality. And these age-adjusted rates would exist if the population under study had the same age distribution as that standard 2000 population. So age-adjusted rates are always preferred over other kinds of incidence and mortality rates. The next question is about breast cancer, so that will be for Dr. Simmons. Why do Black women have such a high mortality rate for breast cancer, but they have the highest or the best screening rates for breast cancer among all the other groups? Dr. Simmons?
Okay, well, this is an interesting question. The shortest answer would be biology, but I can elaborate a little bit more. Keep in mind the statistics in this report are really big picture, which is important to have those kinds of big pictures. The slide specific webinar that links to this question would be when the slide that broke down breast cancer diagnosis by stage, and I was saying at the time that that was TNM, tumor nodes. If you think about that, it's important to have those staging, the criteria, and we have them for all cancers, but it basically boils down to anatomy, the size of the tumor, the number of lymph nodes. And in breast cancer, for sure, that correlates with prognosis, but obviously there's a lot more to it. And with the tumor registry on individual cases, I do believe that there's reports of the estrogen receptor, progesterone receptor status, the grade of the tumor, perhaps the HER2 status. Those are also prognostic factors. So the question is, what about mortality? So we really have to know that data to see that, to be able to correlate, and that is really beyond the scope of this kind of report. But it's an excellent question, and there are probably other factors as well that where medical science is on the brink of a better and better understanding all the time. That would be my thoughts on it's not you can't, it really is not a simple answer to that question.
Well, thank you for helping us gain some more information on that. Thank you. The next question is about colorectal cancer, so it goes to Dr. Guerra. Since Black males have the highest incidence and highest mortality rates for colorectal cancer, and they are historically difficult to screen by way of colonoscopy, what is the most effective method of colorectal cancer screening for Black males?
Well, thank you for that question. That's actually a question that's very near and dear to my heart. I spend most of my time trying to screen the African American population around the University of Pennsylvania, which is concentrated in West Philadelphia, which is our neighborhood. And that population is 76% African American. And what we found was that that 5 zip code geographic area has a much lower screening rate for colorectal, for colonoscopy, screening colonoscopy. And so we built this program to address the barriers that were reported by that population. And what we found was that the Black males did not come to the program. In fact, 2/3 of the participants in the navigation program for colonoscopy are female. So I've tried to better understand why Black males do not complete colonoscopy in particular, and I've learned a whole variety of reasons as to why. Many of them report that they don't want to have a colonoscopy because of some negative attitudes. The invasiveness of the colonoscopy procedure is something that concerns them. Many of them are basically in jobs that where if they were not to go to their work and instead come here for a colonoscopy and have spent half a day, they would not get paid. Many of them are dealing with other pressing life issues. There's literacy barriers to completing the colonoscopy instructions, and so there's a large variety of reasons. And what we've found is that that population is more open-minded to undergoing either a FIT test, fecal immunochemical testing, or an FOBT test. It's not invasive, you don't have to take off work, and FIT is actually better adhered to than FOBT. As some of the audience may know, with FOBT you have to follow a strict diet, avoid certain medications like aspirin, and with FIT you don't have to worry about that, and it's less samples. And so in that case, the Black males may be more open to screening with an FIT or FOBT test. And you know, experts around the country say that the best test is the one that the patient will complete. Sometimes there's not a full understanding of that on behalf of providers like me, because providers want a colonoscopy. We seem to have read all the evidence and come away thinking that it's more effective. And it's also a preventive test, right? Whereas FIT and FOBT will detect cancer early, colonoscopy has the advantage that it will detect cancer but also remove potential cancers in the form of adenomatous polyps. So that's why we prefer it. It has much more been the supported test among physicians, but we have to become more open-minded, and providers have to just recommend the test that the patient will complete.
Well, thank you. Our next question is to Dr. Moritz, and it's one I think we all struggle with. Why do some people who never smoked still get lung cancer?
Yeah, that's a question I get asked in the office a lot. There does seem to sort of mirror Dr. Simmons' answer. There's some biology. There's certainly people that can smoke an entire lifetime and never develop lung cancer, and there's people that smoked for a few years in college and, you know, their early 20s or 30s, and then 20, 30, 40 years later have lung cancer. So there seems to be definitely some difference in patient biology and the way carcinogens like smoking affect the patient's airways and linings of the airways. The other factor is that not all lung cancer is from smoking. It's from radons, from diesel fumes, it's from some of the other things I mentioned during the presentation. And there does seem to be a little bit difference in female and male biology, and that may account for some of the reason why female rates are not dropping off like they are in men. And then there's another issue that's not talked about very often, but it's the fact that smoking and issues like radon don't add to each other as far as the incidence of lung cancer. They multiply. And so if you've got a significantly high radon level in your house, or you're around asbestos is another one that works in the same way, and you happen to smoke, your incidence or your risk of cancer is exceptionally high. So it just depends on sort of the whole picture and the patient's biology.
Well, thank you. And the next questions I'm going to combine, and they're for you also, Dr. Moritz. You mentioned, a new modality for lung cancer screening. What is it, and who is eligible for it?
Sure. Lung cancer screening is a low-dose CT scan or CAT scan. And by low dose, that just means that you get around 2 units of radiation compared to 7 to 10 if you're getting a regular standard chest CAT scan. And what this does is it looks for small spots on the lung called nodules, and it's a fairly quick and easy thing to have done. Now, who is eligible for that? According to the new Medicare guidelines that came out in February, anybody who is 55 to 77 who has 30 pack years of smoking, that's equivalent to smoking 1 pack a day for 30 years, and who has still actively smoking or quit within the last 15 years is basically eligible based on those guidelines. And that was based off of a national lung cancer screening trial that showed a 20% survival in patients that were screened over a 3-year period with CAT scans over standard chest x-rays.
All right, thank you. We have probably our final question here for Dr. Guerra. For colorectal cancer screening, are there currently resources from the Department of Health or other organizations to design patient navigation programs to increase colorectal cancer screening, particularly among those groups that have the lower screening rates?
Thank you. I appreciate the question because I've partnered with the Department of Health to try to create 2 potential resources and now working on a 3rd. There may be many others, but I can talk about the few that I know. So in collaboration with the Pennsylvania Academy of Family Physicians, the Department of Health sponsored a CME lecture earlier this spring, which is entitled Building a Successful Navigation Program for Colorectal Cancer Screening. You heard from the talk today how important we foresee those programs in enabling increased screening rates throughout the state. And so this is a talk that's available to anybody. In fact, I know I accessed it, and it's available to anyone who logs on to the PAFP website. And the second one would be a monograph that we're working on also to inform those who are interested in creating navigation programs on how to build a successful navigation program. And finally, the 3rd that is also in the works, and you will probably hear more about in the near future, is that the Department of Health is collaborating with the American Cancer Society to create a statewide summit, probably in December. The tentative date is December 3rd. Whereby we will bring together all the key stakeholders so that we can make progress in increasing colorectal cancer screens in the state. That'll include health systems and payers and specialty organizations and the PAFP and the Department of Health and many, many others. And what we'd like to do is create work groups to address the different barriers we have across the state so that we can increase colorectal cancer screening rates. More to come on that. It's going to be a whole full-day conference, and hopefully between the DOH, the American Cancer Society, and others, you'll start hearing a little bit more about that in December, as December draws near. Thank you.
Well, thank you, and that was our last question. I want to thank our panelists, all of our sponsors and data organizers for an excellent hour together. To our attendees, you will be receiving different emails about posting this webinar, as well as the questions and answers that came in that we could not attend to today, and a future invitation to the fall webinar on the burden of cancer for other cancers besides these four. So with that, I'd like to thank you, and today's webinar is concluded.